Love Boise State Public Radio podcasts? They are free to enjoy, but not free to produce. If you can give, your support helps keep shows like Idaho Matters and Scandalize available to everyone. Donate now at boisestatepublicradio.org.
From the studios of Boise State Public Radio News, I'm Samantha Wright, filling in for Jim Gaudette. It's Idaho Matters. When an ambulance rolls up to an emergency, crews have a lot of tools to treat injuries, but only about 2% of EMS crews carry blood in their rigs to use for blood transfusions that can save lives. A new program in Canyon County is trying to change that. It's a partnership between Canyon County paramedics, St. Alphonsus, and the American Red Cross, and now EMS crews have whole blood in their ambulances. Here to tell us more about it are Dr. Caleb Mintzer, trauma and acute care surgeon and director of trauma ICU at St. Alphonsus Regional Medical Center, Boise, and Jade Parsons, the division chief of training with Canyon County Paramedics. Both of you, thank you for coming back here on Idaho Matters. How you doing today?
Doing great. Thanks for having us back.
No problem. Okay, and I'm going to leave it up to whichever one of you wants to answer this question. But just describe the program and how it works. We talked a little bit about this a while back, but we wanted to really get the full story. So give us an overview. How does this work?
So an overview of how it works is we have one rig. It's our battalion chief that kind of roams around and manages the system. And he carries 2 units of whole blood with him at all times. So anywhere in the county that goes on a traumatic event, or if the notes from the caller points to something that a patient might receive blood, he'll try and move to that spot and get blood to the crews. Everyone's trained to be able to use it, so that way we just have less resources that we have to manage and are able to cover a bigger footprint. We keep those 2 units of blood for about 2 weeks, and we rotate them in with St. Al's Boise so it doesn't go to waste at all. So they'll use them when it gets closer to their expiration date, and they give us brand new units with a further out expiration date. So the ones we're always carrying are as far away from expiring as possible.
Well, I was wondering about that. That answers my expiration question, because it doesn't last forever. And, if you don't use it, what happens to it? So it's going back to the hospital, right?
Yeah, so whole blood has the shortest shelf life. It only has about 21 days when it's drawn. And I think by the time Boise gets it, we're usually closer to 20. So they'll give us the newest batch they have, the newest units, and then we'll keep them until about 5 to 6 days from the expiration date. And we go back to Boise and rotate them. Or if we've used them, we just pick up new units with further out expiration dates when we stop at the hospital. And so that way we really focus on limiting waste. Because it's such a scarce resource, we don't want to be wasting that. And so we try and make sure it gets used at all times. And with Boise being a level 1 trauma center, level 2 trauma center, they have the most likelihood of using it over us.
So it sounds like timing and coordination is pretty important to make this program work.
Definitely.
Okay, Dr. Mintzer, how does a patient getting blood in the field help you when they finally come to the hospital?
That's a really good question. And it really gets to the root of the matter of why we pushed this out and partnered with Canyon County to make this happen. We actually have demonstrated several times over and over through some very large studies conducted with our hospital in Boise and several others that looked at outcomes for patients who received whole blood transfusion in the pre-hospital setting. We actually showed somewhere between a 35 and 45% reduction in mortality in these patients. So first off, the first thing that pre-hospital blood gives me as a trauma surgeon and my colleagues is a little bit better of a fighting chance to help the patient. The pre-hospital crews are transfusing and practicing a standard of medicine that we give and use in every large trauma center in the country. And so it extends our reach to the accident at the accident site or the site of injury, and extends the golden hour, which is the 1 hour time frame that we talk about in trauma that a patient really has to get to definitive care where we can have the most impact. So whole blood, to break it down, is really what you bleed, right? It's all of the clotting factors. It's all of the plasma, and it includes all of the red cells that we would exsanguinate at the site of injury. And it just gives it back in the normal, natural ratios, right? For a long time, we tried to give people ratio or balanced resuscitations where we give you a set number of cryo, a set number of plasma, a set number of packed red cells, all in hopes of essentially just getting back to giving whole blood. And so giving you back what you were bleeding allows us to practice a paradigm called hemostatic resuscitation, in which we're using your body's innate ability to form clots to help us clot off whatever's bleeding so we can actually intervene surgically when you arrive to the hospital.
Okay, so two things are coming out of what you just said. First off,
Yep.
I think there may be a misconception that when, if you're getting blood in the ambulance or on site, that's just to replace volume. But it sounds like what you're saying is that this goes further than that when you are finally in the hospital and trying to get people better.
But 100%, 100%. Bleeding patients have a constellation of problems besides just bleeding, right? There's some metabolic downstream consequences. And in trauma, all trauma patients develop what's called trauma-induced coagulopathy, where our body does not clot. And so, a patient involved in a traumatic event initially goes through a couple of phases where they clot really well initially. They don't clot really well. They are coagulopathic to the point where their blood and platelets don't function the right way. And then they become hypercoagulable, where they actually swing the pendulum the complete other direction, and they form clots a lot of times where we don't want you to form clots. And so utilizing that idea and having a good grasp on the physiology of a bleeding patient allows us to use whole blood in the first period of time where you don't necessarily clot very well. And by getting the products that you would normally be exsanguinating, the platelets, the plasma that help with clot formation, we allow ourselves a little bit of a head start on what you'd be getting in the trauma center, but you get it in the back of the rig.
Okay, and the other thing you said was, and I'm just going to latch on the higher number, 40%? 40%?
Yep, up to 40%. So a couple of really big studies came out, and one of them that we participated in showed that we took a sample of about 1,600 trauma patients, the most severely injured, and we showed that if you received whole blood initially on your initial presentation, we actually were able to reduce your mortality upwards of 47% compared to people who just received component therapy.
Wow, that's incredible. Okay, where does the money come for this program? Because it's we talked about coordination, but this got to cost a little money.
It 100% costs some money, and I'll defer to Jade on the pre-hospital side, but I can tell you St. Alphonsus really got behind this and has put some money and some capital and some effort. We're the ones that are handling the changing out of the blood, and that requires staff, and our blood banking staff is outstanding. We cannot do this without those guys and without the Red Cross. And, St. Alphonsus just sees this as an opportunity for further community service and really living the mission of what we say is, people are going to get healthcare no matter who you are. And if it costs us a little money to deliver the best outcomes, we're going to stand behind that.
And as far as the pre-hospital side of it goes, we've been trying to do this for about 3 years, and we were ready to do it about a year ago, and it was the cost that really stopped us. And about the same time, we actually got a temporary levy override, and that increased funds that our community was able to vote and give for us was really what gave us the ability to do the cost up front. And most of it was a big cost up front, getting all the supplies, equipment, training. There was a substantial training rollout to get everyone qualified and ready to be able to do it, so there weren't side effects or blood being wasted or anything like that. And so because of that levy, we were able to do that. And then the partnership with St. Al's is the most benefit there. As far as that helps with the ongoing costs. Without that partnership, even with the levy, it would still be difficult to do. So I think the combination of everything lining up in the last year with that levy override and our partnership with ALS working together is really what brought and made the overwhelming cost of pre-hospital blood manageable.
Okay, so without compromising any patient privacy, this program's been up for a few months now. I want to ask both of you, Jade, has this made a difference in the field?
Oh, substantially. Like just to reverberate what Dr. Mincer was saying, we've had at least, we've given 7 units so far since February. And when I was looking at it initially, I guessed when we helped design this program that we would have given 10 in the first year. And we're going to far exceed that. I think heading into the 100 deadliest days, we're already close to my guesstimate. But as far as outcomes, we've had, I think all the traumas have made it and been discharged home that have received blood except one. That one ended up receiving upwards of 50 units in the OR and didn't make it. So I think we gave him the best shot. But I think the best things that I've seen come from blood is we've had at least 2 that I can think of that prior to giving blood would have been intubated pre-hospital with a crash airway. And what we've seen in the past prior to blood is we give saline. We're basically giving fluids. We're not giving them what they're bleeding, like Dr. Mincer was saying. And what we find in the past is that all we see is an increase in the numbers on our monitor. We're not seeing a big change as far as patient outcome. We're just seeing numbers change on our monitor that make our chart look a little better. And as we implemented whole blood, at least 2 of those cases, they were setting up to RSI, to intubate, to take the airway, which in trauma is generally very risky. And giving 1 unit of blood, the patient turned around so much. Not only did their vitals increase, but the patients woke up, began talking, their mentation returned. And they were so stable that not only did they not get intubated by us, they didn't get intubated by the ER. And the first time they were intubated and their airway was secured was in the OR, which is the ideal circumstance where they have the best benefit. And most all those patients had significantly better outcomes, were able to be discharged home on all cases except 1 in the trauma setting.
And Dr. Mincer, how do you think it's going?
I have to reiterate what Jade says. It really does make a difference. People are showing up to the hospital much more stable, or transiently stable, right? Like as opposed to just getting transfused normal saline or lactated ringers and for all lack of better terms, basically salt water. We're now giving you something that truly expands your volume and helps with the delivery of oxygenation and helps with the delivery of the clotting factors and everything to the site of injury. And so, there have definitely been some significant benefits without going into too much. And like Jade alluded to, most of these patients who receive whole blood, with the one that I know off the top of my head who did not survive, have all made it out of the hospital with good outcomes.
Wow. Okay, some estimates say if this program was nationwide, 10,000 lives could be saved a year. Jade, is your operation being used as a model now for other areas?
Yeah, so when we designed this over the last 3 years, we have done every step to make sure that it was replicatable. So when we got blood dropped to the paramedic scope, we changed the whole state. Everything we've done has made it so it could be replicated easily. Ada County is replicating our model and should be live in October, I think is the last date I heard they're aiming for. I just presented last week at the Idaho Transportation Department across the state showing what benefits we have. And once again, every time we do any of these presentations, it's offering our resources, our protocols, and my time to be able to help build those. I presented at the TSC State Council a couple weeks ago, and I'm already in meetings with Kootenai County up in northern Idaho to help them do it. All of our protocols are shared, how we did it, the why. And then I've been doing blood programs for over a decade now. And so helping them build not just ours, not just to match ours, but finding a program that works in their agencies and in their settings that can still be effective, that can still be used and help patients.
Wow. Well, it sounds like an amazing program. Good luck to the both of you. And, really appreciate all the work you're putting into this to try and save more lives.
Thank you.
Thank you. It's our pleasure.
We've been speaking with Dr. Caleb Mincer, trauma and acute care surgeon and director of trauma ICU at St. Alphonsus Regional Medical Center, Boise, and Jade Parsons, the division chief of training with Canyon County paramedics, about their new program, getting whole blood into ambulances in Canyon County.
Thanks so much for listening to this episode of Idaho Matters. And for quick news of the day, start your mornings with our podcast. It's called The Connector, Idaho Daily News. And if this episode meant something to you, text it to a friend.
Each story you hear on Planet Money starts with a question. What happens if we refund tariffs? Why are groceries so expensive? At NPR, we stand for your right to be curious, because the forces shaping our world can be hard to see. Follow NPR's Planet Money wherever you get your podcasts and start seeing how the economy really works.